Okay, so now we are talking about testicular and scrotal condition. We have done the testicular torsion. Now we are talking about torsion of appendix testis. This one is torsion of the vestigial remnant of the paramesonephric tract. The clinical presentation is subacute pain compared to testicular torsion. And the blue dot sign will be there, which is a visible blue-black nodule through the scrotal skin at the upper pool. Tenderness is localized to the upper pool. The management is usually conservative, giving analgesia or rest for the patient. This is quite small and very rare, not come regularly in exam. But some recalls is there. A 9-year-old boy present with emergency department with a 12-hour history of the itching pain in his right scrotum. The pain is localized to the upper pool of the testis. On a physical examination, the testis is not highlighting, and the cremasteric reflex is present through the scrotal skin. A small, tender, bluish black nodule is visible at the upper aspect of the right testis. What is the most likely diagnosis? They given us a testicular torsion, acute epididymitis, torsion of the appendix testis, inguinal hernia, and a hydrocele. So this is because of the small tender bluish black nodule, which is very specific for torsion of appendix testis. And also here they say the visible blue dot sign, which is infarcted appendix testis seen through the skin, is pathognomonic for torsion of the appendix testis, which is hierarchy of the Morgagni. Unlike torsion, the pain is often more gradual and insidious, localized to the upper pool, and the cremasteric is present. Yes. So perfect explanation. Why not testicular torsion and torsion where there is severe pain, absent cremasteric reflex, and option B, acute epididymitis. It's very rare in pre-pubertal boys, and also there is positive sign and fever. The next question, a 10-year-old boy is diagnosed clinically with torsion of the appendix testis. So he already diagnosed and he has a localized tenderness and positive blue dot sign. He is hemodynamically stable and pain is well controlled with simple analgesia. What is the most appropriate management? Emergency surgical exploration, supportive care with rest and NSAID, manual detorsion, and intravenous antibiotic. So the best option here is supportive care with rest and NSAID because torsion of the appendix testis is self-limiting condition. So we have to manage it supportively, and the first scrotal support analgesia will be given. Option A, or for the emergency case, it's indicated only for the torsion. And if pain is refractory to medical management, and option C is manual detorsion is for testicular torsion, not for appendix. This is some summary of the same topic. Appendix testis is a vestigial remnant of the paramesonephric or Mullerian tract, also known as hydratid of Morgagni, and the age of which is very common in 7 to 12 years old. And onset is gradual inside use. Physical sign, you will see a blue dot, which is very pathognomonic for bluish discoloration through the scrotum. Localized tenderness is specifically at the upper pool, and the cremasteric sign reflex will be intact. Investigation always made on the history and exam alone, and Doppler ultrasound only to use if the diagnosis is in doubt. First line of management is conservative and NSAID or ibuprofen. Surgical, we will only mandatory if the testicular torsion cannot be excluded. The exam trap of the reflex, cremasteric reflex, if it is absent, it can be torsion. If it is present with other sign and symptom blue dot, then that is appendix. The sudden with aging trap is sudden pain, testicular torsion, itching or gradual pain is appendix torsion. Normal ultrasound trap and normal ultrasound does not rule out the torsion of appendix. Differentiating from the torsion, in torsion there is also highlighting transverse line, severe pain, cremasteric absent. So this topic was very short and small. So now we go with the epididymitis and epididymo-orchitis. This topic is very common, coming repeatedly. It is an inflammation of epididymis with or without the testis, usually infectious. The pathogen in the age of less than 35. Chlamydia trachomatis and Neisseria gonorrhea is very common in age more than 35, or the MSM, E. coli, and Pseudomonas is common. Clinical presentation of epididymitis or epididymo-orchitis is gradual onset of pain and swelling, fever, dysuria, urethral discharge, positive brain sign. This is very important. And pain relief with scrotal elevation, intact cremasteric reflex. Investigation, we do urine analysis, NOTI for STI, and Doppler ultrasound to rule out the torsion. Management is, if it is suspected of STI, we give ceftriaxone, IM single dose with doxycycline 100 twice for 14 days. Enteric pathogen is if there is enteric pathogen, we give ciprofloxacin twice for 10 to 12, 14 days, and supportive rest scrotum, scrotal elevation, and insane. Now we do some recall and eMedici to clear out some questions. A 28-year-old man present to GP with a 2-day history of gradual onset of right-sided testicular pain. So there said gradual onset of testicular pain, right? So gradual onset rule out the torsion. He denies recent trauma or urinary discharge. He reports having unprotected sex with a new female partner 1 week ago. On exam, the right scrotum is shown in a tender, but elevation of the scrotum provides us some relief. This is also can rule out the torsion. The cremasteric reflex also present. This is another good sign. Scrotal ultrasound revealed on enlarged epididymis with increased blood flow. Which one of the following is the most likely cause? Here, they're asking about the causes of the epididymitis. We see the age of the patient is 28 years old. E. coli, Neisseria gonorrhea, chlamydia, treponema, pallinoma, Coxsackie virus. The right option here is chlamydia trachomatis because this patient is an sexually active man under 35. Chlamydia trachomatis is very common in this age. E. coli is most common in over 35. Gonorrhea is most common, statistically less frequent than chlamydia in this age. Syphilis rarely can cause epididymitis. Next question, a 64-year-old man present with febrile illness, red, painless, testicular swelling, scrotal ultrasound shows enlarged epididymitis with a good blood flow. What is the best investigation to confirm the most likely causative organism? If you are asking to confirm the organism, so it is easy to go with the midstream urine culture or MSC. So in this case, and the main over 35, epididymitis frequently caused by enteric organism like E. coli is associated with urinary tract infection or bladder outlet obstruction. Therefore, midstream urine culture is the essential investigation. There are other options of urine cytology, urethral microscopy, PCR for chlamydia. PCR is useful for younger ages of STI, and it's the primary investigation for an older patient while enteric bacteria is suspected. And another question of 19-year-old male present with acute scrotal pain and swelling of ultrasound shows epididymo-orchitis. He is sexually active with multiple partners. Which one of the following antibiotic regimen is most appropriate for empirical treatment according to a Australian guideline? Here, the patient already confirmed by epididymo-orchitis. He is sexually active with multiple partner. This is a red flag. So now we are giving ceftriaxone plus doxycycline because this is a suspected STI related to epididymitis less than 35-year-old. Okay, so we go only with ceprofloxacin if there is an enteric pathogen suspected in older means. So the summary, epididymitis and testicular torsion differentiation. The onset of epididymitis is gradual. The testicular torsion is sudden. Prince sign here is positive and testicular torsion is negative. Cremasteric and epididymitis present and testicular absent. Ultrasound here increase blood flow and decrease. Totally opposite to each other. Epididymitis, inflammation of epididymis. Epididymo-orchitis, combination of inflammation of epididymis and the testis both. Management, again, same, less than 35, we give ceftriaxone with doxy. More than 35, suspected of the enteric E. coli, we give ciprofloxacin only. Supportive care bed-rest and said scrotal elevation. Initial investigation is MSU STI screen. First, pass urine PCR naughty for chlamydia, gonorrhea. Imaging scrotal Doppler ultrasound, we only to exclude the torsion. There is some trap, the torsion trap, if the pain is sudden and the cremasteric is absent, do not wait for ultrasound, go with surgical exploration. If Princeton is not 100% reliable, so that's why clinical history of the onset is more important. A mumps link, if the patient has a preceding parotid swelling and fever, think mump orchitis, supportive care only, no antibiotic. Partner notification for STI related cases, the current partner must be treated and the patient should abstain from the sex for 7 days until the treatment is completed. So there is a good flow chart someone shared, Dr. Safra. It's about the hydrocell, varicocele, about all of them. So I will attach that. Yeah. So that's nice.